Today we're in leafy Surrey and we're here to talk to Professor Fowler about Fowler syndrome. So Professor Fowler discovered Fowler syndrome in 1985 and was Professor of Neurology at UCL until her retirement. She has now agreed to become FSUK's patron and we're very excited to have her on board, and we're now going to speak to her.
It's not a common condition, and I think that I need to make quite clear about everything I say from now on that I did retire 10 years ago and I'm out of date really with current medical thinking about it all. So what I'm going to tell you is what I remember and what I wrote down about what I did. What happened was that I saw a series of young women who were otherwise completely fit and well, who'd got no significant other medical history, who simply couldn't pass urine. And it said in the literature that this was hysteria, this was a psychogenic condition. And that really didn't seem quite right to me. And I was working with a urological colleague, Professor, he is now, Roger Kirby, and he presented me with a series of these women because he was working on the urology ward, and he brought these patients across for us to do tests on. And I started to do electromyography because that was my background, and recorded this extraordinary signal that I hadn't recorded in any other muscles in the body. But because of my background in my training, I knew that it was highly likely that this activity was associated with an overactivity of the muscle that we were recording from. It's a pity that we can't play it to you, but it can sound very like a helicopter. And I know that other people who'd recorded it before me thought it was some interference in the equipment. It was very likely that it indicated that the muscle was overactive, and we were recording from the urethral sphincter. So that produced the idea that there was an overactivity of this muscle, and that in itself was the cause of their failure to pass urine. The women that I saw initially were mostly young women with no precipitating identifiable cause, who'd just gone into retention. And characteristically, they would go into retention and presented casualty and be found to have more than a litre in their bladder. They wouldn't have any sense of urgency to pass urine, which actually was rather extraordinary. But the significance of that didn't really dawn on me to begin with. But it was that they had painless, enormous urinary retention and no other features, no other neurological features, and no other urological features, and no previous history of having had a significant urological problem. So it was baffling for the doctors they presented to, it was baffling for the patients, but I was pretty sure it wasn't hysteria. Because we identified the condition through the electrophysiological recording, that seemed to be the gold standard. But the trouble about doing that test is it's uncomfortable, but also that it's not, I'm going to use the word quantitative. It doesn't tell you how much abnormality there is. You just hear a bit of information from the end of the needle. The great advance was when we started to measure the pressure in the urethra and found that that was higher than one would have expected for a woman of that age. And that really secured the whole concept that it was that there was an overactivity of the muscle, it was causing a high pressure, and it was causing the retention. Almost all described to me how something would grip as they came to take the catheter out. And that exactly fitted in with my hypothesis that this was an overactive muscle. I think because they found the catheterization so difficult, they were considered to be very difficult people, but they had a good reason for finding it difficult. And once that was explained to the urologists and the urology nurses whose job it was to teach them self-catheterisation, I think that probably made a difference, because up to that stage I think they'd just been seen as difficult and awkward, and why wouldn't they do self-catheterisation? It would just completely resolve the problem. Whenever there's any challenge to any widely held view, people are always reluctant to come on board. But I remember that there was a neurologist that I had a very great respect for, and he said, yes, there had to be some other explanation for this. In general, a lot of the urologists were delighted that some explanation had been offered, because these patients were extremely difficult to manage when nobody knew what the matter was, and it helped to have some explanation. But I think the greater opposition came from the neurologists, who weren't in any way involved with the management of the bladder. They were just asked to say, does this patient have a neurological basis for their symptoms? I mean, at one stage it was said that this was a presenting sign of multiple sclerosis. Actually, I never saw a patient with multiple sclerosis who presented in retention. It simply wasn't. If they had retention, they had lots of other neurological features. Often the patients were sent to neurologists and all the scans were normal, and it was concluded, no, they hadn't got multiple sclerosis, didn't know what they'd got, perhaps it was psychogenic. One of the things that helps a high proportion of women with proper Fowler syndrome is neuromodulation. That was a condition, that was a procedure that had been introduced to treat bladder overactivity. So it was a complete mystery as to why it should also work in urinary retention. But it worked extremely well, and the key finding that I remember observing was that it gave back sensation. And with the neuromodulation, their sensation of bladder fullness came back, and following that they were able to empty their bladder again. So that, to my mind, indicated that there was some very complicated neural modification going on in some way that I think still isn't properly understood. I used to walk in through a door at the hospital that I think it said, knowledge is power. And that's true, knowledge is power. So if you are able to tell people the likely explanation for their symptoms, I think that's a massive help. Even if you can't say, do X, Y, Z and it will get better, it's a great help to have a name, a recognition as to what you've got. And the number of women who were so thankful that an organic cause had been found. They'd often had the condition for several years before they got to me, and they were just so relieved. They said, I thought it was in my head in the end, and it wasn't. It was in their urethral sphincter. I did give talks about the condition to the British Association of Urological Surgeons, and as a result of that, I used to get referrals from all over the country. And I think by the time I retired, I was seeing one woman a week with retention from all over the country. Some of them did have it, some of them didn't have the condition, but it was seen as being a useful resource. I was seen as being a useful resource to refer women with retention to. What I increasingly recognised was that a lot of women who had retention were taking opiates, and I hadn't been asking them. But once I recognised that this was an association, it became apparent that it really was quite a potent additional cause, because of course opiates on their own can produce urinary retention. I worried about patients who had got pelvic pain for some other reason. There are many, many different causes of pelvic pain who took opiates and then developed retention. But I could never work out which came first. Was it that they started to take opiates and that put them into retention? Or was the pain associated with some cause of the retention? It was very difficult to know. I initially thought that the condition must be hormonally dependent. Nobody, as far as I know, knows the cause of polycystic ovary syndrome. But it can be associated with excessive levels of testosterone, and I wondered if that had some effect on the striated urethral sphincter, because it is it is an area of a woman's body that is very hormonally sensitive. I did think that there was a hormonal profile, but certainly during the time that I was working, those features became much more effectively treated, and so that women didn't suffer from those features as well as badly as they had before. There was things that could be done about that. To get the neurologists concerned about how miserable it was to have incontinence, and also to focus on the massive input that the nervous system has to controlling your bladder. Your bladder can't do a lot of different things. It can only store urine or empty it out. So it's a bit uninteresting in terms of clinical history. And I think that there'd been a tendency, if anybody who had a neurological condition had trouble with their bladder, they'd say it's a nursing problem. But actually there was an awful lot to be learnt as to understand why they'd got incontinence or retention. The problem can happen at all different levels in the nervous system. So I think that awareness was a big contribution. But I think the various methods that we use to help people manage their incontinence were very important, and I was lucky enough to be involved in some of the clinical trials that really were very successful, that transformed a lot of people's lives. That was a really good thing.